Friday afternoon. Thank you so much for still being here with us. I want to start saying something about myself, and perhaps the first thing I could say is I would describe myself as a queer cisgender man, uh, using he, his, him pronouns. I would also describe myself as a migrant. I'm originally from Argentina. According to the Home Office, I'm white non-European, which is a lovely category of being non-something. Um, I come from different fields in terms of systemic therapy. I've been trained originally in systemic family therapy. And then when I came to the UK, came into the world of counseling psychology. So I think professionally, I'm a bit of a bisexual between systemic therapy and thinking and being working as a psychologist. I wouldn't say I am a psychologist, but I would say better, I work as a psychologist. Education and social care are probably two of the massive systems, gigantic systems in which I navigate. As Gail was saying before, I've just finished my professional doctorate in systemic practice with a lot of people that I admire, that became friends with, and it's been such a inspiring and very, very powerful professional and personal experience. And the title of my dissertation is Autism and Learning Disability, Developing a Relationship-Centered Approach for Support Workers in Social Care. And I'll tell you in a few minutes why I focus on this. I need to apologize in advance because I absolutely love PowerPoint. I know that some of you really hate it, but it just gives me the structure I need. It just allows me to, put ideas together. So forgive me for that. Um, I'm here today because I'm obsessed with the fact that social care, NHS, education, different systems around supporting people. And so I'm including myself in those systems. We work with people and we're not considering their relational context. As if we live in deserts, We don't live in desert. I mean, some of us probably would love to. We don't live in a desert isolated. We live surrounded by others in specific contexts. So what I would like to tell you today is a story about my work at the intersection of people living with autism and learning disabilities. Numbers say that there are about 700,000 autistics in the UK, and half of these individuals have a learning disability, something that we call a learning disability, and that the total number of people being diagnosed with a learning disability is about 1.5 million. So let me go not too much because I'm not really interested in definitions and criteria and diagnosis, but just to let you know that some people.
Can you please turn the mics off? If we're not talking, can we just ensure we have our mics off, please? There's some feedback coming. Sorry about that, Fran.
Oh, thank you. Thank you very much. So you're going to hear learning disability or learning disabilities in plural. In other countries, English-speaking countries such as America or Australia, they use intellectual disability as a label. In the past, we used to use here learning difficulties. So you can see all these overlapping labels, and basically I really like this definition from LD, or Learning Disability Charity, MENCAP, that says that a learning disability is a reduced intellectual ability and difficulty with everyday tasks, and then it emphasizes people with a learning disability tend to take longer to learn and may need support to develop, but they can learn. Another thing that I wanted to point out, well, if you want to know more about diagnosis, you can go to the DSM-5 or ICD-10 or 11. I'm going to bring it in a moment, but this is a yes or no diagnosis. So you have a learning disability, or you have a learning disability, or you don't have it. Okay, it's a very binary thing. So there is also an emphasis on the brain. So a learning disability occurs when in the brain happens certain things. Sometimes professionals don't know what happened in the brain, so the cause could be unknown or complex. there are different types of learning disability, which can be mild, moderate, severe, or profound, ways of categorizing people according to their levels of skills and abilities. So let me go to, I didn't introduce this person who is with me in the presentation, which is Sam. She's here. Standing in the left side of the screen. So let me read and emphasize some keywords in relation to these definitions. The ICD-10 says something like a condition of arrested or incomplete development of the mind. I'm not really sure what arrested means in this context, but I'll just grab the incomplete development and impairment. And then let's go to ICD-11, because the ICD-10 is more linked to the old mental retardation definition. And the ICD-11 starts the vocabulary of disorders. So let's call it now disorder of intellectual development. Again, emphasizing that a learning disability is a below average intellectual functioning and adaptive behavior. So let me, oops, why is this not working? Oh, there we go. So then I found, while kind of creating the context of what I wanted to inquiry about, I found really interesting that autism spectrum disorder, you know, the definition of autism and the criteria, the diagnosis, and disorder of intellectual development share the idea of a disorder. So I went to the dictionary and I found that disorder, according to Cambridge Dictionary, means confusion, lack of system or plan organization, irregularity, disturbance, interruption of normal function. So again, normality is in the picture, isn't it? An illness of the body or mind. So it's putting together these categories of body and mind that Sami spoke about yesterday so thoroughly and so brightfully. So irregularity, disturbance, interruption of normal functions. So if something is not normal, then we might have this category of intellectual disability. So let's imagine that this character that I created for this presentation let's imagine that it's called Sam, that she's 21 years old, that she has a label of autism and learning disabilities. But what we are finding in the system is that people who live in this intersection often have something else. Behaviors that challenge, EGPD, emotional unstable personality disorder. Gail was mentioning yesterday about trauma attachment difficulties as associated labels, and also mental health diagnosis. So one question that I hear a lot from working with systems of support around people with a diagnosis of autism and LD is we need a full picture of Sam. We want to know Sam completely, you know, we want to have a full picture of how she is. And I'm a psychologist in that expert position. I'm expected to give a full picture of somebody. Another question that I found really, really interesting, and I'm sure that you have a lot of ideas around this, is the question, is it behaviors or is it mental health? You know, is it one thing or is it another? We can go back to that in our dialogue later. Uh, so as part of my inquiry, what I found is that I needed to explore more about social care. So I developed what I call an ecology of the industry of social care. So the person who receives a diagnosis of a learning disability has access to support from the system of social care. Some people describe as an industry. So I think this is interesting to also to emphasize that the kind of the bigger category is learning disability. So you have a learning disability, and then you could have also autism or other diagnoses, because you can have autism and then services are completely different, if any, unfortunately. But if you have a learning disability, then you can have access to services. So you become a service user, a customer, You're also called a person who uses the service, people who use services, or a patient. You have an NHS number, and your life, very important and sometimes very intimate aspects of your life, go into an online system that professionals like myself fit into and write to and report to, so that all the professionals that work around the person identifies a service user, then they can share information, because you know, you have lots of people interacting, and I'll tell you a bit about that in this next slide. I'm not sure whether you're able to see the some of the sorry if the typography is not big enough, but what I'm trying to reflect with this is that around the person identify as a client or customer or service user, there is, of course, carers, meaningful relationships, families, but then the social care system set up arrangements with sometimes private companies called providers of care and support, who hire people referred to as care and support workers. They have a team manager, they have a practice lead in you know, in ideal scenarios. Sometimes they have a positive behavioral support practitioner, a PBS practitioner. So this team that revolves around the person is also supported by what are called community learning disability teams, CLD teams, composed by social workers, community nurses, occupational therapists, speech and language therapists, clinical counseling, forensic psychologists, psychiatrists, systemic psychotherapists, depending the case. This is to show you that there is a whole, if you're not familiar with social care in England, this is to show you that there is a whole universe revolving around the person, private organizations, public organizations, and resources. Um, so in my inquiry, I started to think, who are some of the most relevant um, members of the system of support around the person identified as a client. And I found that support workers are really essential part of the system, because what providers of specialist support, what they do is they hire these workers. They offer in you know, some of them offer some training and supervision, and then these are the people who spend the time with the clients, with the service users. I think this is interesting. So we can. I told you before how you know, the whole system refers to these workers. I think another term that is missing from here that I've just realized is frontline staff. Frontline staff. And it's just you know, so easy to think about a bottle and a front line, and that kind of maybe because English is not my native language, I kind of make weird associations. But there is something about that relationship that I thought I needed to explore more. So before exploring the relationship, I went into the world of care workers, and I found out that there is in this social care industry, there seems to be what I call a low wage and untrained care staff model. And what I mean by this is that if we go into numbers, support workers have the highest staff turnover rate in the UK economy at the rate of 31%. So we are saying that 3 out of 10 care workers leave their job after 1 year. In that first year, they leave their job. Um, Research says that they go into different other settings in social care. It's not that necessarily they leave social care as a whole, but they move. There is a lot of people moving around services. We're talking about a lot of people. Think about 700,000 care workers. Half of them are employed part-time. 82%, this is a female force. And you know, if you're interested in this, there is a lot of research around understanding and having conversations and you know, exploring the world of care workers that I included in my dissertation. Not it's not that I've done it, but others that I got inspiration from and name it in my thesis. 20% identified themselves as being from a Black, Asian, and minority background, and 16% are foreigners. So I again, I was, working as a psychologist, I started to think about what are the economic conditions of these people, of this group of people. And I found that the hourly pay is very, very low. It's a very, very low wage model. And the work that they are expected to do is very, very high specialist. Isn't that a paradox, I thought? That there are thousands of vacancies, and Brexit does not help at all to this situation. And what really started to worry me the most is the fact that care workers report frequent incidents. This is a kind of an old survey, really, but it would be interesting to do this again. Incidents of verbal abuse and physical assault with care, with support staff, sorry, with service users. Support staff report that they have these issues with service users, people identify as having autism and learning disabilities, triggered by what they call misunderstandings and frustration, personal care activities, being refused a service, or the person receiving care and support not getting what they wanted. And I thought all these issues seem to be more related to people really listening to each other and understanding each other. And I thought that was really interesting. So I explore what was going on with care workers, and then I explore what research and literature and NHS was reporting about people autistic with learning disabilities or people with autism and LD. And I found three things that shocked me. The first one is that people with LD and autism are over medicated. A lot of people, I'm not saying everybody, but the report says some people with, sorry, PWLD means people with LD. I'm putting it here, not necessarily because I think I agree with it, but I just wanted to embed my presentation with different wordings and concepts that that go around the system. They are over medicated. That's one thing. Another thing is have a lower life expectancy, and also were shockingly discriminated during the COVID-19 pandemic. So let me go one by one, and let me move this here. So NHS England has been for a few years now asking for the over medication of people with LD and autism to stop. Psychotropic medication used for psychosis, depression, diagnosis of psychosis, depression, anxiety, sleep problems. They are given to people because their behavior is seen as challenging. Who sees their behavior as challenging? The support workers, right? And the systems of support. And NHS England is saying every day 35,000 adults with LD are taking psychotropic medicines when they do not have the health conditions the meds are for. Whether what we think about diagnosis of depression, anxiety, that's another issue, isn't it? But this is shocking, the over medication of people with LD and autism. The second issue that NHS England is raising is this program that has been going on for a few years now, the LEADER program, that reports that people with LD are dying of not having enough support from the health system. So they die of illnesses, issues that are completely treatable. Pneumonia, sepsis, constipation, cancer. So they don't have the level of care and treatment that, that the general public have. They don't receive the same quality of care as people without a learning disability. And the third thing is that there seems to be also an issue around using the Mental Capacity Act, which is a legal tool that allows professionals to make decisions for their clients, for people with LD. So what the LEADER program is asking is that professionals need to make sure that they follow all the protocols and all the procedures, so that they make the right choice, and they have into consideration a lot of things, such as, for example, making sure that the person does not have capacity to make a decision. So let me go now with the third issue, which is what happened during the COVID pandemic, which is what charity, LD charity Menka reported. And Gail, you mentioned it yesterday, so the DNR is a document that a doctor makes that indicates a medical team not to attempt cardiopulmonary resuscitation, CPR. So the DNRs are usually made for people who are too frail to benefit from cardiopulmonary resuscitation. But MENCAP denounced last year that healthy individuals having issued a DNR simply because they had a learning disability. This year, a few months ago, MENCAP also urged the government to urgently vaccine everyone with a learning disability as a priority, which later happened. And also a public health study, a Public Health England study, has found that people with a learning disability were 6 times. We need to revise, what new research says, whether this 6 times is even, is even an increased number, more likely to die from COVID than the rest of the population. So with that, having some views around what was going on in this social care industry from the side of the support and care workers, and then from the side of the other side of the interaction, autistic with a learning disability, I thought, well, what's happening in that working relationship? If people are getting training and support workers receive some training, what kind of training is it? What kind of approaches do we have? And that's when I decided to analyze, as a part of my inquiry, 20 trainings and approaches related to autism and learning disability. So I made my own map. I'm not saying this is the truth. I made the map that was useful for me as a professional working with support workers. So I found, interestingly, that there seems to be this spectrum of a very rich field of trainings. I'm not sure whether other countries in the world have such a richness in terms of a variety of different theories and applications, and developed by institutions, social care institutions, national charities, universities, education and communication professionals. I found very little yet. There are some really interesting initiatives, but there are very little training and approaches offered by people with lived experience or by people on the spectrum. When there is, they are asked to be invited as guests and offer their personal experience. But it would be interesting to see training companies like what Rachel has set up in terms of what she was telling us before. So I kind of reshape the map and say, okay, what am I finding in this map? With my kind of systemic social constructionist systemic lenses, what is going on with the care relationship? And I found a spectrum really of experiences in which we have management and control. Lots of different training and approaches focus on controlling people, managing people. And then on the other side of the spectrum, approaches such as gentle teaching, the work that Pathway Associates does, I think nationally, around seeing others as equals, human beings in relationships. So I found this kind of map, and we could argue, you can tell me I have different experiences with this or that. I'm just sharing you my map. So let me show you some examples of what I found. PBS in itself is it seems to be a really interesting theory, but then it depends also how it's applied onto people, because I found that then support workers, they are asked to monitor, to be in this surveillance position that we were discussing this morning in terms of gathering information about the customer behaviors and write down, this person, this is what he or she or they do. Every half an hour, they do this, they do that, they wake up, they have breakfast, they have a shower, they have the meds, then they have half an hour or 1 hour downtime, and then they have lunch, and then they go for a walk for an hour, then they come back home, and everything's really, really prescribed in terms of what's happening. And I'm talking about this PBS framework, and also what's coming in the next slide, which is active support. But in particular, PBS, what is expecting also is that care workers start to monitor, to observe, to analyze behaviors behaviors from the person, the behaviors of the person that they are working with. So imagine that you have people constantly watching you and talking about you and writing about what you're doing, and what happens before you do something and what happens after you do something. Um, in this example, this is what I was telling you before around about access support in terms of keeping people busy. We need to keep them busy. They need to be productive. They need to learn. They need to be. We need to upskill them. We need to teach them um, functional skills. So we need to teach them functional skills because, is it because they are dysfunctional? In the example number three, and I'm so sorry if you are a professional working in active support, I think it's great, depending on how it's been applied and how you position yourself in terms of power. But this manual that is freely available online, it might sound reductionist. You might say, Fran, you're just taking out of something out of context. But look at this example. If challenging behavior occurs, follow this approach: ignore, redirect, and reward. If a person starts to behave disruptively, you need to do 1, 2, 3. And I understand that we live in a culture that values, protocols, pathways, approaches, models. Tell me what to do, give me structure. There is something cultural about that I found fascinating. But sometimes maybe is it too much, perhaps? um, Apologies for the next slide. It might show something that some of you might find distressing, and these are about pictures of people being physically restrained. So if you just want to turn it off, or having this warning, you want to go ahead, it's fine. But I want to I felt I needed to share with you this pictures about a training on Team Teach, Citrus, MAPA. These are techniques in which support workers are trained in what they call positive handling. These physical interventions are called positive handlings. And they are categorized according to different techniques. Some of, for example, holding techniques. And what I found absolutely incredible is this picture that shows us a demonstration of a holding skill technique. And I don't know whether you're familiar with working with people with LD and autism, and you're familiar with physical intervention. Reality seemed to be very, very, very far away from this picture. So thank you for being there, continuing to pay attention. Let me tell you then what I did. So I found keywords and I found key themes in terms of, this approach is focused on communications. This one in the environment. This one's in some of the interaction between carers and clients. Some others about behavioral management. Some others, as I told you, about activities, access support. So it's very seems to be very fragmented, the narrative, and this is a generalization, but seems a very fragmented narrative that focus on fixing specific aspects of the person designated as a client. So in a way, I imagine this toolbox. If you need help with communication, you need to learn this and this and this. If you need help with behaviors, you need to learn that and that and that. And then this is also a culture that absolutely loves specialism. Sorry, it wasn't a pause premeditated. I just needed some water. But we love specialism in this culture. Everything is very fragmented and everything is like, so this is it, this is that. So I thought, is it that perhaps okay, many training and approaches, as I was telling you, ask support workers to manage, monitor, control, train, demand compliance. But the interesting part is that most of these trainings, most of this market is not available for support workers. Most of these trainings are very costly. And if you remember, the wages of support workers will hardly be something that people might pay from their own pockets. So there is a whole industry around this, around the training, the autism LD training industry. Mary and Sammy spoke about some of this yesterday. Um, so most trainings include generalities about autism. So autism is this, LD is this, people with autism this, people with autism that. So it creates this template that if I'm a support worker, I do this lovely training with lovely people, you know, 1 day training, somebody comes for a couple of hours and talk about their experiences being an autistic in this society, challenges, this and that. Well, I know, I meet with, you know, I comply with the tick box. I've done my training in autism. So, but then what I find is that people go back to their job environments, you know, back to work, and they found a gap between that theoretical understanding and some of the things they've heard, and we were talking about something like this with Carol before this morning. You know, every person is different, but if you have that template, you work, and if the person doesn't fit that template, maybe there is something wrong with the person. Because as was it Rebecca that was saying yesterday, if you don't you look at me in the eye, you're not autistic, are you? You know, so the exceptions are seen as, you know, what's going on with you. So strategies and techniques are manualized according to goals. You know, you need to do this. You want to decrease challenging behaviors, you need to do step 1, step 2, step 3. There are some mentioning about relational components of the work, but it usually refers to the service user social network. So friends and family. The relational component is about friends and family. It's not about care workers, my relationship with care workers. If I'm a support worker, the only approach, I think it's a low arousal approach by Studio 3. It starts to, well, it doesn't start, it offers an understanding of reflexivity and why reflexivity is important. So I thought, okay, we have this toolbox, we have these themes, but we need something kind of a meta level, isn't it? And I thought of this umbrella. Could this umbrella be the care relationship between the service user and the support worker, because it's so important and it's so foregrounded? It's so backgrounded in the analysis in my experience too. So should I think about a care relationship then? And this is when I thought, and now I'm going to drink water. I'll give you a couple of moments to read this slide. This is when I started to try to connect the dots. I love that expression. What is the relationship between societal narratives around autism and LD, learning disability? We've been hearing a lot about that yesterday and today, about people being incomplete, about incomplete development, below average functioning, about being disordered or disturbance and irregularities. What's the relationship with that, with the eugenics agenda? What's the relationship with those societal narratives to the toolbox approaches? What do support workers learn? What do they learn about autism and LD? Because that is the way that, you know, that those ideas are going to shape their interaction and their support, aren't they? And then what's the relationship between these toolbox fragmented approaches and having a low wage support workers model, where people, you know, with all the things that we, you know, I told you before, and what's the relationship of all this with having some people over medicated? And in a shockingly way that makes NHS, you know, make a program and alert everybody in the system. So at this point, I started to think this is really, really important for me in my context, because when we say there is a problem and we say we need a full picture of some, the question is, how and why do problem saturated narratives often revolve around autistic people with LD? So if there is a problem, it's not the system, it's the person. I think, Gail, you said before, systems that create a problem, something similar. So in a way, if there is something happening there, it's because the person has autism and LD. It's not because the system is failing or the system, presents difficulties. So my invitation is then a shift in the focus of what we're observing, working with, writing about, thinking about, from the individual to the care relationship. Because this care relationship, and you're going to see why, is very, very complex. Because people don't live in isolated silos. We don't live in isolated silos. We might be a little bit more, prefer a little bit more loneliness and isolation, but we live surrounded in relational contexts. And people in services live in relational context. So who is important in some, going back to Sam, who is important in her life, in her emotional and relational life? Often support workers are these artificial family, should we call it maybe that way for a minute? Artificial family, they hang out, they watch a movie together, they might go for walks, they might talk about, very personal stuff, but then these people move on, and they, after a few months, they move on. How do how does a person feel? How does a service user feel about if you have a system that pushes people out because of many the different things that I've discussed before? So focusing on Sam, how is she responding to others, and how are others responding to her? Um, who are we? Where am I in the relational map of the clients that I'm working with? Whether are service users and support workers. If I am the observer, author, and I need to explain you. What I mean by quotes is that observer, we can't never be neutral observers, can we? We always decide. We decide. We see something. We see a piece of the picture, don't we? We see a piece of the story, but we construct also what we see, don't we? But we do that punctuation. So we are observers, not really. So we are more authors. So what story are you telling? What story am I telling? What editorial choices am I making? You know, what are we foregrounding? What are we sending to the background? Um, so I guess this is probably, I'm assuming that many of you share this question: how can we invite people to complement the biomedical view of a disorder in the brain, something that happens in here, with understanding people in relationships and contexts, particularly because people coming from neuroscience are having this let me think, this kind of neuroscience upgrade. There seems to be a really relational approach to neuroscience coming from some really interesting people, saying, no, relationships affects the brain and the brain affects relationships, and this is false. This dichotomy is not really that much. We everything is neurophysio psycho relational, because if we have a holistic approach to see ourselves as human beings with other human beings, isn't it? So I thought that's really interesting. So inspired by Buddhism, I thought Buddhism has really a fascinating model of understanding the mind, but I thought, and another idea is impermanence, the fact that everything is changing moment by moment. Some of the stuff we're not that aware, because it's not obvious. So maybe when we think, oh, we are now in July, or we see a picture of ourselves in contrast with, and we contrast it with some years ago, we see the passage of time. But everything is really changing all the time. Relationships are changing. We change according to how we slept, how we sleep. My neighbor woke me up at 3 o'clock in the morning. I didn't sleep, since 3 o'clock. Then I had lots of coffee. I wasn't really sure about how this talk would go, but here I am. So it would probably be different if I weren't as accelerated, as hyper, as we love to say in our system, as hyper as I am, thanks to caffeine. So I choose to represent the movement of life with the idea of a ball that moves around. It's always moving. representing perhaps a relationship. Could I use a ball to represent a relationship? Let me check the time. Yeah. So what I did is I learned, let's go back to the part of my inquiry in which I analyzed some approaches, and I show you some highlights of that analysis. So I thought of, okay, if I have to think of a care relationship, and if I have to learn from what I feel is relevant from what else there, I would say there are four main issues, that I can see as very, very at the foreground. Because at the end of the day, support workers are people who are hired to go to a place with somebody for a period of time, right? So whether it's a home or the shop or shopping or go for a walk. So I thought, what if we focus on communication and behavior? How let me go. So how people communicate and behave towards each other, how people perceive each other, how people share and relate to what is a home and also a work environment, and how people share the time that they spend together. So four areas. But what is different perhaps from other things that I've been reading and approaches and experiencing is that this is all interrelated. It's very difficult to separate what's what, isn't it? Because as we know, this is also created in the language and in the story that I'm sharing and that I'm hearing. So I designed a visual representation to think about and to reflect on the care relationship. And I'm very, very passionate about saying that this is not a tool to fix. There's nothing to fix. We are people, we're not computers, we're not iPhones, there's nothing to fix. This is a tool to it is a visual prompt. We always think about visual prompts for autistics, for people with LD. Why don't we all use visual prompts, including professionals and care workers? So I designed this visual prompt for care workers and myself and as you can see, I'm very visual. I need to see things. I need to see concepts. So this is to reflect, to share, to talk and explore how people are getting along with each other. Okay. Unfortunately, due to the time constraints, I'm not going to explain you in details what the model and the approach is about. And I'm doing quotes. I'm being, sarcastic. This is supposed to be humorous, because I criticize models and approaches because they offer this recipe to work with people as if they are working with an IKEA furniture. You need to do 1, 2, 3, 4, 5. This is not IKEA. This is a prompt so that people can reflect on their work. What I'll do is we can get in touch. You can get in touch with us from from the website of these conferences. And once my dissertation is published, you can, if you're interested, you can read all about it there. I think it's going to be probably about a couple of 2-3 months. So let me go back to this idea of this story, for example, and this is going to be sort of brief, but let me share with you some snapshots of a story. Let's think about Sam. Okay, she's at home. She's supported by this care team who works with her, and they say they're having problems, issues, difficulties, behaviors that challenge the system, challenging behaviors, whatever we call it. And the first thing is it's about Sam. She needs anger management. Okay, so psychologists, please come and work with Sam. She needs the one-to-one work. So then, oops, let me see. This is not, yeah. Oh, there we go. And then I go to Sam's house. This is her house. She lives in a nice flat, and Fiona is working with her that afternoon. And Fiona says, I've been working in learning disabilities for 20 years. What are you going to tell me? I know how to work with this kind of people, I'm aware that it sounds pejorative. It doesn't. I don't mean to criticize support workers. They do an amazing job with the resources they have, which are very, very limited. Okay, but what I'm criticizing is the template that trainings, approaches, and perhaps us as a society are reinforcing. And then Sam says, let me oops, I need to. Sam says, um, I've always had problems with these agencies. I want to move out. So now Sam's start to be non-compliance in a way with the system, isn't it? Uh, she wants to move out. So in a way, people bring their own experiences off the system. The system shapes people's experiences, doesn't it? To the care relationship. And then perhaps Fiona might answer, well, you know what? The problem is that Sam is fixated. I love that word, isn't it? Fixated. Sam is fixated with stuff, and she can be very aggressive. Another one is very intimidating. She can be very intimidating. So again, we have that autism template in which people try to, fit other people. Whether, but this is we were having a lovely discussion this morning around, all these categories in which we fall into. But yeah, maybe we can go back, we can go into that a bit later. So, and then Sam says, well, you know what, this is my home. The problem is that I don't know who's coming every morning, and they are never on time. And then I think, okay, so the trainings usually focus about environments autistic friendly. But what about environments LD friendly? What would that mean? What would that look like? What about environments support workers friendly? What about an environment that is friendly for everybody? And I'm not negating or backgrounding uh, a sensory friendly environment. Of course not. But what I'm doing is trying to include the other bits of the interaction. So perhaps for staff, it's about going to work. No, I work in this house. This is I found this fascinating. Some people refer to work as settings. These are called settings, supported living. What for some people is a home, for some is her home, but for the system, it's a supported living setting. It's a house that's been managed. How many houses do you manage? A team manager might tell, oh, I manage 5 houses. Isn't it that industry and managerial discourse pervades and construct what I think what everything that I'm telling you about. So for service users, it's about having other people, sometimes strangers, participating in their life. Um, and this is the example that I was sorry, the example that I was telling you before. Maybe Fiona says, well, sometimes we have bank staff. People are absent, people are off sick, but they say that you can be very intimidating. And I didn't say anything, as you can see from this snapshot of this little story. I didn't need to do anything. I just needed to create the environment to have this conversation, to facilitate the context, to have this conversation between people who don't get along with each other. And then Fiona, maybe, she's like, you know what, I'm freaking out in this house because I never know what's going on. And usually staff teams are composed of several support workers. It's not one person that might visiting Sam, depending on her needs, whether she has complex needs, whether she has other associated diagnoses or behavior as a challenge, depending on many different things. Sam might work with 6 to 8 people every week. So can you imagine having 6 people in your house visiting every week? I would really, really struggle with that. I would really, really struggle. And having to interact with so many different people who, what they do, they bring themselves, and they bring the next slide. Each person brings their own characteristics to the care relationship, their own personalities, their age, gender, sexuality, ethnicity, culture, class, language, education, abilities, race, experiences in services. So, and then you have this crossover, isn't it, between uh, uh, each person with a service user, and then the service user with each person, and then each one of the care staff with each other and the organization. So different levels of complexity that I usually completely ignore in terms of what's going on in the system. So let me go now, and this is my last 5 minutes, and thank you for being there and continue to pay attention to me. These are just brief snapshots around uh, what I hear, themes that appear in practice. Sometimes, especially if providers try matching staff with clients, according to their compatibility. For example, people who prefer to work with female staff or male staff for religious reasons or gender reasons, or they just prefer, um, uh, uh, it's a desire. So that's something that sometimes is being considered, and this is another example of how the conversation might evolve. When he's angry, he makes racist comments, and the idea that some autistics with LD might learn from the media, from society, from their communities, from their families, to say certain things, to produce an effect on people, but not really understanding the meaning of that. So I think the challenge, in my case, is to facilitate those contexts, to allow those conversations to happen, when they're usually about things that are very hurtful. Um, Let me continue with another example. Staff make their own theories, hypotheses, and theories of mind about the service user they are working with. For example, she sees young staff as more vulnerable. That's why she's so confrontational or refuses to engage. So people have their own ideas and their own hypotheses about what's going on. And again, the challenge is to explore, but it's not one. So if you're working, if you come from systemic and family therapy, you work with the family system, I guess we're talking about the same here, isn't it? To work with a whole support system, but we are talking about 8, 10 people. If you include other professionals, we're talking about 15 people revolving around one story and one problem. Um, Reflexivity invites support workers to think about their connection with their clients. This is another really interesting hypothesis. She gets along really, really well with me. I think she sees me as a mother figure. The problem will be, maybe next year she retires. I'm thinking aloud with you. So what's going to happen to that connection and to that care relationship, isn't it? Uh, Sexuality is such a massive taboo, and I've been so moved, and it's been such a privilege to hear some of the other presenters, especially Felix and Rebecca yesterday, talking about sexuality is such a massive taboo, and people who don't follow the heteronormative pathway are often described as confused. I think she's confused about her sexuality, or maybe another person, maybe he's exploring and hasn't decided yet. And as my colleague presenters explained yesterday, non-heterosexuality is more prevalent in autistic population, homosexuality, bisexuality, and asexuality. And autistic people are 6 times more likely to not identify with their birth sex. Felix said this yesterday. Precisely. So sexuality is really the elephant in the room. For those of you who work in education, schools and colleges still don't talk about it, generally speaking. CQC is asking providers, please offer specialized training to staff. This is something that we need to address. And another theme is, another conversation is what happened with the forensic system. People stuck in the forensic system, people with LD and autism, who are at risk of going through the forensic pathway because they hadn't had any of this educational psychoeducation. So I guess at this point, one of my final, questions, thoughts I want to share with you is how can I help this group of people to connect and to see each other as equals in a care relationship? And in this case, what would this story be like? How different would this story be if Sam didn't communicate with verbal language? Because Sam, she's able to express her needs and to say what she wants and what she doesn't know. But what would happen if this wasn't the case? What is that added complexity to the exploration of this hypothesis and this co-construction of narratives with the support system, when everything is pointing at the person who is a service user. So this is recapping of what we've discussed, what I've discussed really, the person and the context. I told you a little bit about the industry of social care. I told you a little bit about my inquiry around training and approaches. Why do we need a relational approach? How would that look like? And intersectionality as a massive element in the room. So finally, well, these are just some ideas to really start the conversation. Why is it important? Well, because we are for granted reflexivity. This is essential for understanding and valuing what makes us all unique and different, service users as well as staffs. Then the question around what's going on with current trainings, around more oriented about doing with or doing to than being with. And perhaps as a result, we have support workers who need to perform certain expectations, and this impacts on the care relationship. And also because a relational center approach or a relational approach includes a sensitivity to intersectionality, as I've tried to illustrate with support workers as well as clients. And finally, how can I do my bit? How can we all do our bit so that the social care system becomes a system for everybody and not a system of oppression? Apart from voting a different party, what else can we do? Thank you very much.